Greetings, my name is Felipe Gutierrez, and this is our work. Technical skills education, the neurosurgery resident experience in Sylvian picture splits and microsurgical aneurysm clipping, a comparison between Pterional and Minipterional craniotomies. When we are talking about neurosurgical education, we must remember that the attending surgeon job is to guide the trainees regarding what tasks are safe and appropriate for the resident to perform, while the trainee job are to improve their surgical skills through the years. In our neurosurgical department, we offer a 5-year program. We have the intern year, the junior residence years, and finally, the senior resident years that perform the majority of the cerebrovascular surgical cases. All of these surgeries are performed under the attending surgeon guidance to maintain the patient's safety. The cerebrovascular surgical cases are one of the highest in complexity, specifically that cases of brain aneurysm with the need of Sylvian fissure splits and microsurgical aneurysm clipping. Brain aneurysms can be treated through endovascular or microsurgical clipping. The microsurgical clipping consists of a microsurgical technique in the majority of the case with the need to perform a correct simple fissure dissection without any retraction to the normal brain. The majority of the cases are done through the Pterional craniotomy, the classical craniotomy, or the most new, the Minipterional craniotomy. So we conduct a retrospective study focused on the patient with brain aneurysm that goes to surgery for clipping, but the majority of the surgery was performed by the senior resident. We studied 3 different hospitals. We focused on the surgery duration, the rate of complete occlusion, the blood loss, the stroke on postoperative CT scan, the death rates, and the neurological impairment on the first 3 months after the surgery. We find 108 patients. We exclude 20 of these cases, 13 because were operated by the attending surgeon alone, 4 cases of pericallosal artery aneurysms that don't need neither Pterional craniotomy or Minipterional craniotomy, and 3 cases that were lost from the follow-up. So the remaining 88 patients construct our analysis group. 68 cases of Pterional craniotomy and 20 cases of Minipterional craniotomy. All the cases of the Minipterional group consist of patients with ruptured middle cerebral artery aneurysm. The overall occlusion rate was 95.4%. 4 cases of the Pterional group need reintervention, and no cases of the Minipterional craniotomy group need reintervention. A stroke on the first postoperative CT scan was found in 20.4% of the cases, 16 patients in the Pterional group and 2 cases in the Minipterional craniotomy group. The overall mortality rate was just 9%. All of their deaths in the Pterional craniotomy group and in the subgroup of patients with subarachnoid hemorrhage with high Honan-Hess scores before the surgery. Only 2 patients present an intraoperative rupture, but none of them with follow-up results in the follow-up. The surgical time was minor in the Minipterional craniotomy group, also as the blood loss. At the conclusions, the participation of the neurosurgery residents in the treatment of patients with brain aneurysms don't affect the overall outcome of these cases. Comparing the results from this retrospective study, we find that are very similar with the international literature that concede that the treatment-related complications and mortality rate are higher in the Pterional craniotomy patients, and specifically in the subgroup of patients that suffer subarachnoid hemorrhage with high Hunt and Hess scores before the surgery. Thank you very much.